Hello, everyone. Someone asked me to do a review on the treatment protocol of Shankara Chetty. Shankara Chetty is a general practitioner in South Africa, and he claims that he has treated 4,000 patients with COVID with 100% success using this protocol. So I found one article that he's written, and this is the article. It was published in a newsletter called Modern Medicine. It's not a medical journal, not peer-reviewed. If you look at this paper that he wrote, there's no references, and this is just kind of it's more of a story of how he's been treating these patients and what he feels like is what's going on in these patients. And basically, the gist of it is he feels like they're that they're having a type 1 hypersensitivity reaction. So he says right here, the only pathogenesis that fully explains these outcomes are type 1 hypersensitivity reactions. And type 1 hypersensitivity reactions are basically immediate allergic reactions, kind of like hay fever, allergic rhinitis, um, and in severe cases, it can be anaphylactic shock. And he's correct in that these symptoms that COVID patients have are not the result of direct viral damage, but more the result of the immune system's reaction to the virus. But this idea that it's a type 1 hypersensitivity reaction just really doesn't hold water because type 1 hypersensitivity reactions happen immediately. It's like when you get exposed to pollen, you react to it within minutes. And he says that the hypersensitivity reaction occurs around the seventh day. And that doesn't make sense. If you were having a hypersensitivity reaction to the virus, you would have it within minutes of the exposure. Um, and the way he thinks about it is that he thinks that the reason that older people are getting more severe disease is that they've been exposed to an antigen or an allergen that is similar to the coronavirus, and then when they get exposed to COVID, they're having a hypersensitivity reaction to it. Anyways, his protocol is essentially a combination of antihistamines and leukotriene inhibitors, and then he adds hydroxychloroquine and azithromycin in more severe patients. And so there's an update here. So this was published in October of 2020, and so subsequently he's kind of changed his protocol a little bit, and he's been in a ton of videos on YouTube talking about his protocol. And he's practicing medicine. Uh, by observing what he's seeing and then just trying different things, which is great. And that is how a lot of medical advances were done. But this is kind of like the way that medicine was practiced in the 19th century, where doctors were very observant and they kind of looked at what was going on with their patients and kind of guessed as what they thought was happening and then tried something and and then they tried something different, and they tried something different. And that a lot of medical progress was made using that method, but now we have much more sophisticated ways of dealing with these things. And so while if you have an idea that it's a type 1 sensitivity reaction, you should run, leukotriene levels and histamine levels, and look at IgE levels. And none of that was done. And then, so here's a more updated kind of uh, article, and these are transcripts of the April 30 webinar. So this article was written in October, published in October, so probably he wrote it in September, and then it got published in October. And then this is the transcript of the April 30 webinar. And so he says that what he noticed was that the the badness started happening around day 8. And then he tried on a patient who's critically ill a dose of promethazine. Now, promethazine is also known as Phenergan. It is an antiemetic drug that's commonly used. We commonly give it post-operatively to patients to keep them from throwing up from the anesthesia. But it's also an antihistamine. And he says that that immediately, made them feel better within 24 hours. And then he decided that that got him to understand that he was dealing with a hypersensitivity reaction. Now that is kind of the flawed thought process, because superficially it seems correct because he's using an antihistamine drug and the patient got better. So then you think it must be a histamine related phenomenon or a hypersensitivity reaction, because promethazine treats allergies. It treats type 1 hypersensitivity. So you think, well, I must be dealing with a hypersensitivity reaction. Superficially, that makes sense. But if you think about it, there are many side effects of that drugs do that are not what their primary intent is. For example, if you were to treat someone with ivermectin, which is primarily an antiparasitic drug, and they got better from COVID, then would it be correct to assume that COVID was a parasitic disease? No, I don't think so. Or if you use hydroxychloroquine and they got better, hydroxychloroquine is an anti-malarial drug. Would you make the assumption that COVID is a malarial disease? So yeah, and then we're using fluvoxamine, which is a another drug that's kind of being looked at as fluvoxamine, which is an antidepressant drug. But all these drugs have like other effects than their primary effect. So just because promethazine worked in this case doesn't mean that, number one, does it work in every case, and number two, is it a hypersensitive reaction? Maybe, maybe not. Maybe there's some other factors going on. Maybe there's some other effects of promethazine that are actually what's causing these effects that they're seeing. So superficially, this kind of thought process makes sense, but if you kind of think about it a little further, it doesn't hold water. But anyways, he goes down, and then this is the part where it just doesn't pass the sniff test with me. It says, all in all, I've seen close to 4,000 patients, excluding those I've treated over the phone. So he's treated more than 4,000 patients over the phone. None of my patients have long COVID symptoms. None of them been hospitalized. They were always treated at home and managed at home. So a couple of things. He lives in a city called Port Edward, and this is Port Edward. And if you look at this, it's a very, if you look at this Google satellite image, this is a very not densely populated area, it's a very rural area. And the population of Port Edwards is 4,000. Now, there's more people in the surrounding area, but there's no large city centers. Like Cape Town is over here. These are large cities with lots of people. They're over here in a very not very populated part of the country. And so saying that you saw 4,000 patients from here means that pretty much everyone who got COVID in this entire area came to him, which seems unlikely. And number two, he says this in April of 2021. And then in this paper, he says he saw 200 patients in around when he wrote this in September. So that's about a 7-month difference between here and here. And then in the 7 months, he saw 3,800 patients. That works out to about 30 patients per day. So 30 new patients per day. And so if he was only seeing new patients, he'd be seeing 30 patients a day. If he was seeing patients back, which you're going to have to see how they're doing as you see them back at least once. If you're seeing all the patients back at least once, then you're seeing 60 patients a day. If you see them back twice, which I'm assuming he sees them back more than once, that's 90 patients a day. That is a unsustainable number. There's no doctor that sees 90, 60, 90 patients a day. That's kind of crazy. And then that's assuming that that's the only patient that he treats. He's a general practitioner. He's got to be treating other things as well. So excluding the other things that he's treating, he's seeing 60 to 90 COVID patients per day for a period of 7 months. That just doesn't seem to make sense. And then, anytime anyone says that they have 100% success, I just find that hard to believe. And that kind of reminds me of this guy. I don't know if you remember him, Dr. Vladimir Zelenko. He was kind of famous way early in the days. He was a big proponent of hydroxychloroquine. He says he treated people with hydroxychloroquine, azithromycin, and zinc, and he treated 700 COVID patients with 100% success. And there's no one that has 100% success in anything. It's just not it's just not human, and it's not the way the world works. I mean, if you treat 4,000 patients, even if you did everything perfectly, and even if you had the perfect treatment, there's going to be the rare person that doesn't respond to, even if they're, let's say theoretically there was a perfect treatment for COVID. Um, Even the perfect treatment is not going to work 100% of the time. So those are the things that make me a little bit leery of it. Now, someone wrote this group out of Canada wrote a paper talking about this protocol, and they actually sent this paper to him, Dr. Chetty, and had him review it. See, so they said Dr. Chetty for having inspired this work and offered feedback on a draft of this article. So, this article is actually written as an academic article. As you can see, there are references in the back, and they have references within the paper. And they planned on submitting this, and I'm sure they have submitted this to some journal. As of yet, it has not been published, so it's a preprint journal. Um, but this graph of how they believe COVID works is, accurate. There is an early infection phase, and then they basically, it's true that most of the damage is due to hyperinflation and hypercoagulation. That is absolutely true. So some people's bodies kind of react um, to the virus, and they're unable to clear the virus in the early stage, and they get the severe disease. And so then they talk about um, some treatments for the early inflammatory phase, which are steroids, and steroids are a standard treatment now. Antihistamines. So this is the Chetty protocol: is steroids, antihistamines, leukotriene antagonists. These are they're talking about Montulukast, and that is a Singulair. If you guys have allergies, you'll have heard or asthma, you have heard of Singulair. Singulair is the drug that they're talking about here, and then anticoagulants like aspirin or heparin. And they list his protocol here, and which is a prednisone, 80 milligrams daily for a week. This is a very high dose of prednisone, so this is not a no risk protocol. Promethazine is a pretty safe drug, and so is levocetirizine. This is basically Zyrtec, and cimetidine. This is a H2 blocker, so it's kind of like a stomach acid blocker. So this is same as like ranitidine, Zantac, that kind of stuff. And then anti-leukotrienes. This is Singulair, and then blood thinners. So yeah, it's obvious Dr. Chetty has seen a lot of patients. I don't know if he's seen 4,000. I mean, he claims he has, and we have to take him at his word. That seems like a really large amount, but he's seen a lot of patients, and he's obviously been thinking about this, and he has some great observations, and he has a cocktail that seems to work for him. It hasn't been replicated as far as I know. No one else has tried these protocols. There hasn't been any he has not published any papers that have his data so that people can review them. So it's unclear, are all his patients like did they have COVID tests? Like, how does he know they have COVID? Did they have antigen tests? Did they have PCR tests? What kind of tests did they have? What kind of symptoms did they have? What were their ages? What was their comorbidities? Lab values? What treatments did he give them? For how long? And what was their response? So, we don't know any of these things. He has kind of more of a narrative thing, which he may be onto something. It's just hard for other people to assess without all the data. Um, this is a good paper written by some group out of Baylor, I believe, talking about why it's difficult to have early treatment of COVID and why we actually do need early treatment of COVID. So I'll leave a link to this article in the description. But basically, what's hard about early treatment of COVID is that COVID does very well no matter how you treat them in like 95% of patients. So, if you treat everyone with COVID, 95% of them, you could give them, a chocolate bar as treatment, and they would do great. And you could make the erroneous assumption that the chocolate bar is what helped them recover from the COVID. Um, and then you don't know which are the 5%. Now, there are, older people clearly are going to do worse on average, and people with comorbidities are going to do worse. So if you segment your study population to that group, then your interventions are going to have more of an effect on the outcome. But if you take all comers, like 95% of them are going to do great. They're not going to, if you do nothing, they're just going to get better. And so, whatever intervention you do has to be something that has very low risk because you are treating essentially 95 out of 100 people completely unnecessarily. So, you don't want to give something that has bad side effects to treat people that are going to do fine with no treatment because you're only giving them the risks of the treatment and none of the benefits. That's kind of a concept called number needed to treat. So you're going to have to treat like 95 people to help 5 people. So is that worth it? And that kind of depends on the risk benefit profile of the intervention that you're going to give. And the other problem with looking into these early interventions is that it's hard to run trials with early interventions because you have to get them the drug. So what you have to do is people have to test positive for COVID and then they have to enroll in your study. So, by the time people test positive, they're already symptomatic. And by the time they're symptomatic, the virus has been in them for probably a week. So, early intervention studies, you would ideally want to start the medication as soon as they get tested and get test positive within like that day. But it's very hard to run a trial like that because after they get the positive study, they have to enroll in your study. So after they get the positive test, they enroll in your study. That usually will take, ID, the fastest that's going to happen is that happens on the day of the test. But most people, they will probably wait until the next day, and then you get their information. Then you have to randomize them. Then you have to ship them out the medication. Even if you overnight it to them, that's going to take 2, 3 days. So basically, best case scenario, you're treating them 2, 3 days. They're going to start treatment 2 to 3 days after they get their positive COVID test, which is usually about 7 days after they were infected. So best case scenario, you're starting your intervention 10 days after infection starts. So you're never gonna, it's very hard if you have some intervention that needs to be given within like one day, 1 or 2 days of symptom start. You're almost never gonna be able to hit people at that time period in any trial. But there are several trials, like the Together trial and the Principle trial, that are looking into early interventions. Like this one's looking into ivermectin and an antiviral drug, and then the Together trial, looked into hydroxychloroquine, lopinavir, fluvoxamine, ivermectin, metformin, doxazocin, and lambda interferon. So they're looking into these things. And there are the trials that I mentioned in one of my previous videos where they are looking into ivermectin as well. And I'll try to link that above here. So there are these trials looking at it. And I think that early intervention is important. We focus mainly on late intervention, hospital-based intervention, because most of the academic centers are based around large hospitals and it's easy to run trials in that way. And it's very difficult to run trials in an outpatient setting. Early intervention. But ideally, if we could find an early intervention drug, that would be best. And people are looking into it. The few early intervention trials that have been done that are successful have been these monoclonal antibodies. They clearly do work and have some benefit when given early. like the Regeneron monoclonal antibody therapy and other monoclonal antibodies. And those can be done because there's just a lot of money to back those kinds of trials. So they will, they can recruit patients and they can recruit people into the study because they can pay people to do the work of doing this. Because you need large numbers in these early intervention trials because just most of them are going to do well. So you can't run a study with just 100 people because randomly, if you just pick 100 people, most of them are going to do fine no matter what. You need to have studies of, several hundred to several thousand people for early intervention trials, and that's very expensive. And that's why the only ones that have been done are for these monoclonal antibody therapies because there's some money behind making those, and if they sell those, there's a profit motive for those companies. Um, but there are these other these publicly funded trials that are going to look at cheaper generic drugs and seeing if they are useful in early trials. And there may be something to Dr. Chetty's protocol of using antihistamines and leukotriene inhibitors. And it's very hard to get studies to look into these trials funded because there's not that much money to be made in funding these kinds of trials. So people have to either fund them publicly or have a large consortium of doctors get together to do it. And it's just hard to coordinate. So it's a little unfortunate that that's just the way that the system works, is that it's very difficult to do early intervention trials and much easier to do hospital intervention trials. And that's why most of the trials and information we have about the disease is in the hospital setting. But I think people are starting to understand now that we do need to move to an early intervention model, and that people like Dr. Chetty have been a little bit ahead of the curve in thinking about treating the people early. And that's probably, we do need to find a good protocol to treat people early. And if we can find a safe and cheap protocol to treat people early and prevent them from progressing to the severe disease, that would be excellent. And I think that we are headed in that direction with a lot of these larger trials, and hopefully we'll get some information. So far, fluvoxamine looks very promising, and there's some other drugs. Um, Obviously, the monoclonal antibodies are useful, but they're very expensive and they're not very available outside of very wealthy countries. So that's not really probably a long-term solution. You can't treat everyone with monoclonal antibodies. So we do need to find a relatively cheap, inexpensive, and low-risk medication to treat people early and try to prevent this. So this was a little bit convoluted um, of a video because it's kind of a complex topic, um, and it's hard to make sense of these things because there just isn't a paper written with good data that you can analyze. And so it's just more kind of like my thoughts of what his thoughts are, and I don't know how useful that is actually, because he clearly has way more experience treating COVID than I do because I don't treat COVID. I'm a surgeon. I just find these papers about COVID interesting, and so I'm reading them. But he obviously has found something that works in his hands, and I hope that someone looks into it and sees that if this is actually a useful protocol. The pathophysiology that he's using to back it up, I don't think holds much water, but it doesn't. The pathophysiology doesn't actually matter if the thing works.